to maybe people will find it useful. So at the outset, again, I go back to my guests, without whose blessings the program would not have been completed. During my Foxy election time, I remember the phone calls from Dr. Archana Kumari ma'am, and she was always so friendly. And it was always like a one-to-one and heart-to-heart talk. So, Dr. Archana Kumari, I'm really, really so happy for you that you will be taking over as chairperson of the prestigious quiz committee. And one look at her CV, and you will come to realize how fit she is to, to lead that committee, how much she's worked. She's worked a lot in the whole of the Ranchi OBGY Society, bringing it up. She's the secretary at present of Ranchi OBGY Society. She is also the founder secretary of Indian Fertility Society Jharkhand chapter. She is the elected executive member of National ISOPAP, and we are going to launch the ISOPAP chapter of Bhopal very soon, madam. She's been the vice president of ISOPAP Ranchi chapter, the East Zone coordinator of the quiz committee of Foxy at present, and she'll be taking over as chairperson in January, convener of the clinical research committee of Foxy, from where she gets all the ideas, the brilliant ideas, and has been also the Foxy trainer for RAC and Dhira No to Violence Against Women, and the Foxy Manyata assessor, which speaks volumes of her commitment to social causes as far as women's health is concerned. Madam has organized some
I
wonderful.
think we can stop here. Thank you for your kind and elaborate introduction. It is indeed an honor to be invited by you for this very insightful webinar on a very pertinent topic, that is unraveling PCOS. And I'm so happy. I mean, it is an honor for me to share the platform with legendary personality, the chief guest for today's function, Dr. Rosa Olai, madam. And as you said, during my election time, I was talking to madam, to you, and I have been a great fan of Rosa, madam. I associate her, myself with her since the times he was the Adolescent Health Committee chairperson. And I wrote a chapter for her book. So when I called madam, I just told her about this, and she just told me, "Oh, Archana, you have been working for Foxy for so long. You must come up as in the Foxy." So thank you, madam, for your blessings. With all your blessings and love of all of you, I am here today as chairperson-elect of Foxy Quiz Committee. And of course, anybody would come in the ape of madam's personality, the kind of positive energy she has, the soft spokenness, the humility. I mean, I fall short of words when I'm here to describe Rosa, madam.
Thank you
Thank you.
so much, Archana. You well deserve everything. So sweet of you. Thank you.
Thank you. And thank you, Monica, for being my friend during those election days. We could talk so much, and I wish you all the best in your future endeavor. You are doing wonderful work for Foxy in terms of organizing this beautiful webinar. My gratitude to guest of honor for today, Dr. Sumitra Yadav, madam, Dr. Jayarani Kamraj, madam. I was seeing her, she is here. And of course, Monica, you have wonderful team of young coordinators. Rosa, madam, already told about them, that you are nurturing the young Foxy and also to come up. I always believe a good leader is one who builds up another generation of leader. So that we should be doing always. And I do acknowledge the renowned speakers for today, Dr. Pratap Kumar, sir, a great academician. Salute to you, sir. You are teacher of teachers. I always remember your visit to Ranchi. And of course, Pratik Tambe, sir, has not joined. We were there in ICOG program. I was delivering one talk, and so was the chairperson. So I think he will be joining soon. My regards to Kumudni Jha, madam, one of the pioneer teacher of from Darbhanga. My pranam and Sadir pranam to you, ma'am.
Thank you.
And, my regards to all the chairpersons for today, all the coordinators for today. I wish this webinar a series of webinar. Good luck to Monica also. And Monica, you really need a huge round of applause and huge congratulations for organizing this webinar. So all the best. Thank you for inviting me.
Thank you so much.
I would say this would be my first appearance as special guest, maybe in any of the webinars. Thank you for that.
Thank you so much. And you are special. You are very special, madam. And thank you so much for being here. Now, I take great pleasure in introducing our guests of honor. And they are guests of honor because we really honor them. We love them with all our heart. And I take great pride in introducing Dr. K.S. Jairani Kamraj, ma'am. Madam has been she was the past president of OGSSI. She is a shining luminary figure in the great city of Chennai, where she is director, Akash Fertility Center and Hospital. She has done phenomenal work in the field of sexual health, and we have to pay credit to that the whole society, how it's grown, the number of webinars, talks she has taken. I think the whole of COVID period, I listened to minimum 4 to 5 of her talks. Dr. Jairani took that topic, which is a very, it's a topic which not everybody can handle and speak in a very confident manner, and the message gets across that how is sexual health important. So, madam, congratulations for that. She is the immediate past president of OGSSI, vice president of TAPISAR, joint secretary of TNFOG, advisory council member of the World Association for Sexual Health, and the joint organizing secretary ISAR 2015. Madam has been the recipient of several great awards. She is doing phenomenal work in southern part of India in all the 4 states, all the 5 states rather. And madam, we are very honored to have you as the guest of honor. We'd like to have a few words of blessings from you, ma'am. Dr. Jairani was with us, no? Neetu?
She's here. I think she needs to be unmuted.
Yes, ma'am, she was there. Yeah, I'm here only. I'm unmuted. Can you
Yes.
hear me?
Yes, ma'am.
Can
Yes,
you hear
ma'am.
me?
Yes, ma'am. We introduced you.
Yeah. Thank you. Thank you, Monica. Thank you for the nice introduction. It's an honor to be a person of this, of your, I mean, it's really, I don't have words to say about your commandment in your Synergy Club. And I'm very honored to be a part of this webinar. A very special gratitude to you for this honor to be. And I'm very pleased to share this along with Madam Roisa. Madam, it is a real honor for me to be with Madam and all the senior people from your society, that is from the Darbhanga of OBGYN Society and Saharsa and Sitamar OBGYN Society. I'm really pleasure to have, to be a part of this wonderful webinar. And it's really a very important content that you have chosen in this September month, which is a PCOS month, about the unraveling PCOS conundrum. And that is a very important aspect that as a practicing fertility specialist and a gynecologist, we look upon the women's problem as a PCOS as a holistic one, which really have a greater impact in the women's life. And really, it is amazing, Monica, that you have chosen a very nice topics and a very doyens in this specialty to talk on the topic, and great persons like Pratap Kumar sir, Pratik, and you yourself talking the various aspects of PCOS, which is really commendable. And I really appreciate your initiative on this Synergy Club, bring out various knowledge from the senior academicians, and that is a real work that you are doing with your passion for this subject. And I'm really honored to be a part of it, Monica. And I really thank you for this opportunity. And also, I'm really wish you all the best for all your future endeavor. You are a very commendable person working with passion, with so much of interest in each and every aspect of women's life. And definitely, a women's life is to be made very beautiful with all this knowledge packed work that you're doing. And I'm very thankful, Monica, for making me a part of this webinar. And a very heartfelt congratulations for you. And also a wishes for your future endeavor. And I really wish this will be a grand success. And thank you so much.
Thank you so much for your kind words, Dr. Jairani ma'am. And all the best for your endeavor in Foxy this year. We want to see you as chairperson of No to Violence Against Women Committee, for which you're contesting. All the best. And my platform is always open for you, ma'am. Whenever you want to speak, whenever you want to present something, whenever you want to be, speaking to the whole of India. And taking the program forward, I would like to
thank you, Manisha, and thank you, Monica, for your nice words. Thank you so much.
Thank you, ma'am. And now I would like to introduce our guest of honor. from our own state of Madhya Pradesh, from the city of Indore, a very, very great teacher, a person who is very close to me and Randhir, who has always been our mentor and well-wisher. Dr. Professor Sumitra Yadav is President-elect of Indore OBGY Society, which is a vibrant society of more than 500 members now, one of the leading societies of Madhya Pradesh, which has got 3 vice presidents, so many chairpersons, and many accolades to its credit. Madam is the professor and a unit head in the prestigious MGM Medical College of Indore, which has produced several great academicians and luminaries all over India. With a teaching experience of more than 3 decades, she has been responsible for organizing several great conferences like AICOG 2022, ISAR 2019, MPOX 2019, and has also held the post of Secretary of IOGS in 1920. Madam is the training member and technical expert at NACO, Ministry of Health and Family Welfare from 2006 till date, and has also been awarded several awards like HIV Utkrisht Seva Award, Nari Shakti Award, Nai Dunya Naika Award, Nai Dunya Award for Utkrisht Chikitsa Sahyog, winner of Dr. C.S. Dawn Award twice for Best Paper Presentation in Maternal Care, Young Scientist Award, and the State Award of Karnataka CBSE National Topper. So, Madam, you have been a topper throughout your life, I think. Madam is the chairman of MDSR Committee Indore Division. She is very active in social work like Mahila Utpiran Samiti, which is very, I think it will be closely correlated with the No to Violence Against Women also. MGM Medical College and Nodal Mahila Niti Ayog. And again, she is very active in combating violence against women and harassment of women at workplace. And of course, the POXO Act. Madam is an expert member and in the advisory board of PCPNDT, District MTP Board, ART Regulation District Committee, executive member of FOXY Endometriosis Committee, Practical Obstetrics Committee, and the IAEC. So very active in FOXY right from 2019 to 2023. Member of the Indian Child Abuse, Neglect and Child Labor Act, POXO, with more than 50 publications in international national journals, Best Paper Presentation Awardee in BreastCon 18, Best Paper Award in Endoscopy in Endogyne at Agra 98, written 13 chapters in textbooks, 3 in workshop modules, and the editor of 3 workshop modules. Welcome, Sumitra ma'am, as a guest of honor. We would like to have words of blessings from you, ma'am.
Thank you very much, Monica. It's indeed a pleasure to be here. To actually see Dr. Rosa here, she was there when I joined Gwalior as an assistant professor some 30 years back. And it was really, the moment I saw her, those memories come back, flashing at you. You have been a very dear friend, you and Randhir, and I wish you the best in your all future endeavors. Basically, MP is one, India is. We wish to see it come out. PCOS is a
Madam, your network is...
best. We have asked my PGs also to join because they will be the ones who will be benefiting from this. This is the entire scenario you have covered by stalwart teachers. It would be very nice to hear Dr. Pratap Kumar. I've been hearing him for over 30 years, I should say. And of course, Pratik, dear, and you. It will be very nice to unravel this mystery right from genomic analysis to the actual scenario. I wish you the best, and I wish all the Archana Kumari and Jayam Kamraj the best for their future endeavors. Thank you very much.
Thank you so much, Sumitra ma'am. Thank you for sparing the precious time to be with us in the evening, especially on a working day. Before I move on to speak a few good words about my coordinators, I would like to acknowledge the presence and the great support of all the chairpersons for today's webinar. We have with us Dr. Kumudini Jha ma'am, President, Darbhanga OBGY Society, again a person who has always been with me in my journey through FOXY. Dr. Kalyani Singh ma'am, who is the President, Saharsa OBGY Society. Dr. Rajshri Purbe ma'am, who is Secretary Darbhanga OBGY Society, Dr. Anju Singh, President Sitamarhi OBGY Society, Dr. Manisha Khare from Bhopal, the past President of Bhopal Obsgynae Society, Dr. Sangeeta Thakur, Secretary Saharsa OBGY Society, Dr. Lata Gupta, Secretary Sitamarhi OBGY Society, and Dr. Varuna Pathak, the past Secretary of Bhopal OBGY Society and a very dear friend. Thank you all the chairpersons, and just a little word about my sweet coordinators who are really, I can't express myself when I start to speak about these three girls of mine. Dr. Neetu Mishra, I don't want the CV, Dr. Vishal, I can speak about them. Dr. Neetu Mishra, Dr. Purva Bhatkur, Dr. Nandini Singh Bhati. They are all very, very academically accomplished, very busy gynecologists, working in great medical colleges, and having small children, struggling with the work and profession, family life balance. But there's not a single task which I give them and they don't do before time. So I'm so grateful to you, all three of you. You are, if I had three backbones, you would be my three backbones. So thank you so much.
Thank you so much, ma'am.
So
Thank you,
much.
ma'am.
So,
Kind word.
so,
Thank you.
so now I would like for Neetu to take the program forward and start session one, because Dr. Pratap is waiting since such a long time for all. Thank you so
Yes,
much.
we will start with our scientific session, and thank you very much, ma'am. This is my proud privilege to be part of Synergy. And for the first session, we have Dr. Pratap Kumar sir. He is professor and head of the Department Reproductive Medicine Division of KMC Manipal. He will be speaking on case scenarios and the latest guidelines in PCOS. To chair this session, we have three eminent faculty from Bihar. Dr. Kumudini Jha ma'am, President of Darbhanga OBGYN Society. Kalyani Singh ma'am, President of Saharsa OBGYN Society. And Dr. Rajshri Purve ma'am, Secretary of the Darbhanga OBGYN Society. Can we have CV, please? Dr. Kumudini Jha ma'am, she is President of Darbhanga OBGYN Society and ex-head of the Department of Darbhanga Medical College and Hospital. She is also past Clinical Secretary of Darbhanga OBGYN Society. She is very eminent faculty, has papers in many national and international journals, and has been invited as eminent faculty in many national conferences and CMEs. We welcome you, ma'am, and we will surely be benefited by your presence in this webinar. Our
Thank you.
next chairperson for the session is Dr. Professor Kalyani Singh Madam. She is founder and president of Saharsa Obstetrics and Gynecology Society and emeritus professor of obstetrics and gynecology at Lord Buddha Koshi Medical College, Saharsa. She is also chairman of the same medical college. She is also member of editorial board, Journal of Gynecology and Obstetric Advancement, UK. We welcome you, ma'am, to chair this session, and this is our honor to have you on this webinar. Third chairperson for the session, Dr. Rajshri Purve ma'am. Due to some busy schedule, she could not join, but she will be joining in the middle. She is secretary of Darbhanga OBGY Society and is very keen academician. Now I hand over the session to our chairperson to introduce our speaker and carry forward the session, please.
Hello.
Yes, ma'am.
Yeah, very good evening to everybody. And to start with, let me thank Dr. Monica, a dear friend and a very sweet, down-to-earth person, and equally gentle coordinators for having me here. It's a pleasure to be on the same platform as Dr. Rosa, Dr. Prateek, and Dr. Monica. And it's an honor to chair a session in whom Dr. Pratap Kumar, the most sought after gynecologist of Manipal, is speaking. Also, the three chairpersons here, we have been colleagues, so that is also a very happy event. The topic, guidelines of PCOS, is a very pertinent topic in the present scenario, and it is very much in place because of the number of PCOS patients that we are seeing. And it has been there have been so many inclusions and exclusions in this the PCOS guidelines, right from the Rotterdam criteria to the phenotypes to the Positian criteria. And Dr. Pratap, he's he's been the national vice president of FOXI in the year 1999. and he's been an inspector examination advisor to the National Board of Examinations. He's been an examination in several undergraduate and postgraduate university candidates in several universities, and he has been appointed on the editorial committee of several journals. He's been the president of the Karnataka State Obsgyne Society, and also has been a member of the task force of Human Development and Disease Biology, Department of Biotechnology, New Delhi. And it has been a member of the and Child Health Indian Council, ICMR. So he has a lot of accolades, awards, and publications from the IFS, the Indian Society of Assisted Reproduction, and the Kuti Lifetime Dr. Kuti Achievement Award from 2011 to 2012, and also the Dr. D.K. Tank Reproductive Healthcare Promotion Trophy. And he has more than 300 publications, and he has presented more than 1,000 presentations in national and international conferences. I don't think there's anyone who must not have heard him in these conferences. So just a brief introduction about the topic, that is the Monash Guidelines of 2023. This has this is the most recent one, and they have included the opinion of the ESHRE people, the ASRM, the European Endocrinological Society, and they've graded it. That is grading of recommendations, assessment, development, and evaluation in their framework. So they say that it is only that the two criteria, like the clinical or biochemical hyperandrogenism, and one ovulatory dysfunction or PCOM or raised AMH is enough to diagnose. You don't have to do the whole panel. And initially, we were not doing the free testosterone levels, but now they've included in it. And they've dealt with all the aspects, taking into account about pediatric endocrinology, dietetics, the psychological issue, what Dr. Rosa was talking about depression in children, and lifestyle management, bariatric surgery, where is it needed, metabolic syndrome. Now, if the patient is a case of diabetes with PCOS, the best test is the OGTT. And if the patient is a case of PCOS going into pregnancy, we have better watch out for PET. And the BMI, of course, that is very important. If it is more than 25, you can give semaglutide. So they've dealt about the obstructive sleep apnea, the sexual problems, everything. And in the diagnosis and treatment also, they've taken into account about adolescents. Like just now, Dr. Jairani was saying, and Dr. Rosa, the children come with the diagnosis of PCOS, but it is not to be diagnosed before 8 years post-menarche, because acne and the polycystic ovaries are there even in normal adolescents. The most important thing they're worried about is their cosmetic appearance, the acne, the loss of hair, hirsutism. And there was a case which Dr. B.C. Chakravarti had said, that she committed suicide just because she had hirsutism and because of peer pressure. It is so depressing. So in these patients, you need to give combined oral pills with anti-androgenic factors in it. And when the sex hormone binding globulin goes down, then naturally the free testosterone rises. And in this reproductive age group, it's a different issue. Generally, they come with a complaint of infertility. So they have dealt with what are the guidelines for treatment, be it GnRH analogs or letrozole or clomiphene citrate, and what are the contraindications, what are the side effects like OHSS. And it's not only that, it's in the reproductive age group, even in menopausal patients. They also experience complaint of hyperandrogenic features. And of course, in PCOS patients in menopause, you have to be careful about endometrial carcinoma. And whenever we talk about AMH levels, we should always take the history of drugs or LOD when the surgery has been done. And of course, it is affected by the age and the BMI. So let's hear from our learned speaker, Dr. Pratap, about these guidelines in detail. Thank you so much, sir. And we invite you for the talk.
Thank you, Madam Jha, for introducing me so well and for the subject introduction as well. Monica, special thanks to you for inviting me. And it's a pleasure to be with all of you, the seniors and the juniors on this platform. I would take you through the next 25 minutes on certain case scenarios so that we understand the guidelines as well. I always say PCO syndrome is a confusing syndrome of three. Everything is three in them. What are the three things? The Rotterdam criteria said three things: chronic anovulation, clinical and or biochemical evidence of hyperandrogenism, excluding other etiological factors, and of course ultrasound PCO. Presence of any two of the above is PCO, according to Rotterdam criteria. And if you look at the pathophysiology, there are only three things to understand: hyperinsulinemia, hyperandrogenism, and of course ovarian follicular genesis, which all leads to the same problems of the same polycystic ovarian syndrome presentation. There are only three criteria in the history: oligomenorrhea, increased BMI most of the time, but not always, and excess hair growth. So it's a confusion syndrome of three because the pathophysiology, once again, to say is hyperandrogenism, hyper LH secretion, and of course insulin resistance. And there are three associations who have confused us a lot more, but the three treatments are only reducing BMI, lifestyle modification, induction of ovulation for fertility enhancement, and of course, laparoscopic drilling, which is coming not too very popular at the moment. Now, let me take you through scenarios. I'll put a question and the answer so people who are listening can think about the answer before the question, after the question. I'm only bringing to you today the Eshri Monash guidelines of 2023, which seems to be the latest now. Now, if you look at this question in your mind, a 26-year-old lady, an early Paris woman, is worried as she has gained weight in the last 1 year. So she has gained around 3 kg in the last 1 year and gets cycles once in every 40 days. Now, the guidelines, if you look at them, does she fulfill the criteria for irregular cycles? She's a 40-day cycle. So the guideline, the answer is, the guideline says less than 21 days or more than 35 days is PCO suspicious problem. So 40 days means she comes under PCO. You have to suspect less than 8 cycles per year. Irregularity may be normal in the first year of post-menarche because pubertal transition, and more than 1 year to less than 3 years post-menarche. Once again, less than 21 days, but they put it as more than 45 days after 3 years. So within 3 years, I think 35 days. After 1 to 3, within 1 year is 35 days or any time. But generally, more than 1 year to less than 3 years post-menarche, less than 21 days to more than 45 days is considered abnormal. So I think 40 days comes under the gray zone. The next is another very young girl comes to us, 14 years, and she has 35 to 40 days cycle. Menarche when she was 12 years old. And what's the next step of management? She's worried about that. So the guidelines clearly says, once again to repeat, more than 1 year to less than 3 years post-menarche is 21 days and more than 45 days is considered as irregular. And this woman or the girl can be reassessed after 8 years post-menarche because the hypothalamus maturation occurs by then. And of course, we always have to put them as at risk for PCOS, but it may not be PCOS at all. The next case is 30-year-old Nali Paris eager to conceive. She is a known case of PCOS but has a BMI of 18. That means she is a lean PCO. She wants to know, does she have to do any exercise? As Dr. Rosa mentioned, though she has no excess weight gain, the guidelines is very clear about it. She doesn't have to exercise to reduce weight, but she can exercise to build the muscle. Building the muscle is important because insulin resistance affects 75% of the lean PCOS, and muscle strengthening exercises on 2 consecutive days or per week. Avoid weight gain is very, very important. The guidelines has actually not specified particularly, but in general, I think it's understood that a lean PCO must increase the body mass by doing some exercise so that the insulin is absorbed and the insulin resistance goes away. So the next scenario is 29 years nulliparous with irregular cycles with PCOM, means ultrasound diagnosis of PCOM, and a BMF of 17. Is there a role for androgen estimation? So a young girl comes to us with typical irregular cycles, PCOM, and the question is, should we do androgen estimation? The guidelines clearly says total and free testosterone should be done to assess biochemical hyperandrogenism in the absence of clinical In the absence of clinical hyperandrogenism or minimal signs, biochemical assessment is of great value. So, what does it mean? If you find the hirsutism is present, it's a very clear evidence of PCOS. One actually need not do, but the recommendation is if you have a doubt, then you do it. But I think the guideline says it's always better to have a free testosterone and a total testosterone. But I, for one, would think if somebody is having a strong evidence of hyperandrogenism, this could be pushed aside for some time. But however, this can be done as one of the recommendations for PCOS. The same patient is currently using OC pills. Is there do you have to worry about this? Because is there any specific instruction she needs before getting androgen estimation? So if you decide to do androgen level estimation, which has been incorporated in these doubtful clinical scenarios, we should understand OC pills will increase sex hormone binding globulins. You measure after 3 months of stoppage of OC pills. So, the washout period has to be emphasized in a person who is taking OC pills before you actually estimate any biochemical evidence of PCOS. So, another question is when you talk about hirsutism, we know about Ferriman-Galway scoring. So, what is the modification of this Ferriman-Galway scoring? What is considered normal? So, you'll find that a resident who examines the patient from head to foot, what is this Ferriman-Galway scoring? If you look at the Google that and find out there are 9 areas which have been covered, and if you look at that, the forearm and the lower leg are not included for the scoring. So you don't have to worry about forearm and lower leg here. It's only the other areas like the back and the chin, etc. And you'll find then consider 4 to 6 as normal. Long back we thought 9, but now 9 is too high. Even 4 to 6 Ferriman Galway scoring, but of course India is a little different because many of the states have a little more hirsutism. So according to the ethnicity, we may consider a little more, but definitely 4 to 6 is considered as abnormal. That means a good clinical scenario, good clinical examination will tell us about the PCOS, and testosterone levels may not be needed always. Another woman, 30 years old, nulliparous, irregular cycles, but no evidence of hyperandrogenism. If you look at the do ultrasound, more than 8 megahertz probe, transvaginal of course, you find more than 20 follicles in one ovary, but 12 in the other. The fertility experts have a doubt. By one ovary, you find 20, other one is 12. Can it be considered PCOS? What is not effective ultrasound marker for PCOM in adults? Actually, do you think is PCO or not when one has less and one has more? That's the doubt everybody has. But the follicle, the guideline says you should do compare follicle number per ovary. So like one ovary has so many, one has less. One ovary more than 20 in one ovary itself is enough for a calling as PCOM in adults. And follicle number per cross section. If you look at one cross section by ultrasound, more than 10 itself is enough. And of course, ovarian volume more than 10 ml is considered definitely PCO. Now, another girl comes to us, young girl, 17 years with irregular cycle. Does she need ultrasound? Should we send her for ultrasound? As again, Dr. Rosa was talking about at the beginning, that diagnosis of ultrasound is not necessary. Difference because in these young girls, the polycystic ovary, multicystic ovary can be a confusion. So the recommendation by the HRA guidelines is that you don't have to do ultrasound because these girls in school have irregular cycles. If you go into ultrasound and you wrongly say PCO, for lifelong she'll be branded as PCOS. So it's very clear there is no ultrasound needed for an adolescent girl. So there is no definitive criteria on adolescent in ultrasound. That's why we don't do that. Hence, not recommended. And I mentioned multicystic is usually distributed evenly, and there is no stromal hyperplasia. In these, ultrasound should not be done. Even if somebody does abdominal ultrasound, it is usually 10 follicles per ovary is considered as PCOM. But we do not do abdominal ultrasound at all, nor any kind of ultrasound in adolescent group unless there is a huge problem of hirsutism. Another young girl, 31 years, with vaginismus is being evaluated for PCOS. Ultrasound examination she doesn't allow. As I mentioned, vaginal ultrasound shows 20 per follicle per ovary is considered. If you do ultrasound abdominally, that means what do we consider as PCO? As I mentioned, trans-abdominal sonography, ovarian volume more than 10, and follicle number per section, per ovary, a section more than 10 in either ovary, if we should be probably taking it as PCOS. So basically, we look at the abdominal ultrasound. In adults, that's what FNPO means per ovary should not be counted on the transvaginal sonography, but you look at the volume. So when you look at the volume, it is important. And if you find more than 10 per section, definitely I think it is a PCOS. But TVS is most accurate in a married woman. Another girl, 28 years, irregular cycles, has high AMH. I know doctors are sticking these pages for AMH for everybody, and she's pretty worried about that. She was told to have PCOS without doing ultrasound evaluation. What is general opinion about the role of AMH in the diagnosis of PCOM? Because people think you can diagnose PCOS by AMH, but the ASHRAE guidelines as it can be used to define PCOM, but not for diagnosis. So AMH is not considered for diagnosis. It's only considered for prognosis of medical management. However, a PCOM can be correlated with AMH levels, but it has not been included for diagnosis till now. But you can have a suspicious feeling when the AMH is very high. Because it's important to know that the AMH is done with some liquid chromatography, very good advanced machines and not by ordinary laboratories. So you can go wrong. Somebody may not be having PCOS at all and the AMH come as high and you may wrongly brand her as PCOS. So it's not taken for diagnosis according to the guideline. So one more 32-year-old lean PCOS with BMI for 20. We should also say the question is when she becomes little in the older age group, does she have a cardiovascular risk? I think that we should understand that all these patients who have a risk factor should be evaluated when they become older. But however, all patients must have at least a monitoring of blood pressure, lipid profile, and the sugar profile in PCOS because they are all metabolic risk factors. So the guidelines is very clear. All PCOS patients, regardless of age, BMI, should have a lipid profile, checked at the time of diagnosis, blood pressure annually, and maybe repeat all these things off and on. So one of these patients, lean PCOS, has read online about the risk of developing impaired glucose tolerance with PCOS. Should she be evaluated for her glycemic status is the question. You have to do GTT regardless of the body mass index. But interestingly, FPS and HbA1c can be considered if GTT is not done. So the first choice is GTT. GTT is 75 gram glucose. And 2 hours later, 140 milligram is considered as insulin resistance. And of course, the next choice would be just the fasting sugar. And HbA1c can be considered if GTT is not done. And the recommendation is once in 3 years, you have to assess this sugar in a woman because she may become a diabetic. Her friend also has PCOS and she's worried that she may develop endometrial cancer. How will you counsel her? Because everybody thinks hyperestrogen state, they may get endometrial cancer. So how would you counsel this particular patient? The guidelines is very clear. There is increased endometrial risk, of course, and hyperplasia and cancer in PCOS, but the overall risk is not high. If endometrial thickness is too much because of estrogen only, then in a married woman, probably you would do a biopsy to be sure about hyperplasia or even worse than that. However, the risk is not very high. And I mentioned about this oral contraceptive pill, but do we give this for all adolescents? The answer is yes. I think the combined oral contraceptive pills for management of hirsutism or irregular menstrual cycle is a must according to guideline. And one of the common problem is by doing this, they think that whether adolescent girls can take it. I think the answer is yes. Now, basically, what happens is if you look at these OC pills and hirsutism, it takes 6 long months for hysterism to really reduce. You must tell the patient that if you're giving OC pills, The hirsutism will not disappear in a couple of months, nor it disappears after 6 months. But the incidence of growing back the hair in that woman may be little longer time than now. So OC, because the hair cycle is taking 6 months in the body, hence if at all you give, you should give OC pills for 6 months and not less than that, and beyond that you should continue. So it could be recommended in adolescents and reproductive age adults who are not trying for fertility. Now is eager to conceive. What circumstances metformin should be considered? The guidelines is very clear. It can be considered if more than 25 kg per meter square BMI, and for others like at risk in adolescents by looking at the menstrual history and hirsutism, and of course limited evidence if the BMI is less than 25 kg per meter square. Can improvement of pregnancy occur and live birth rate also increase when used alone or with ovulogens and gonadotrophins? Can be started before COC, helps to prevent OHSS and can stop at pregnancy. The metformin is now, guidelines have not said it should continue in pregnancy. Once there is pregnancy, you can stop it because it can cause further nausea and vomiting apart from pregnancy vomiting. The question of induction of ovulation is letrozole or clomiphene citrate. What's the first choice? The guidelines, as ever, said letrozole. We start with a smaller dose of 2.5 milligram once a day from day 2 to day 6 in a thin woman and an obese woman. Of course, obesity, you have to bring down the weight. There's no doubt about that. You have to bring down the weight. Only then we can start induction of ovulation. I would start 2.5 milligram twice a day in the little of a higher weight category. So you'll find that we have done the fertility treatment, and a 34-year-old woman with primary infertility with PCOS has multiple ovulation induction has failed. That means she is not responding well. Even if she responds, she is not producing good follicles. So she is recommended for IVF with antagonist protocol in order to improve her pregnancy rate. Is this the correct choice? Like if you want to do an IVF in these patients, we have two protocols called a long protocol from day 21 of the previous cycle and antagonist protocol at the present cycle, or we can do. Now, it is usually both are equally good, but antagonist protocol is not preferred over agonist to improve pregnancy rate. However, it's recommended to prevent OHSS. So that means both are okay. I'm using antagonist protocol in IVF cycle. But since it's a general forum of audience, I would not take you through much of these. But remember, when you do long protocol from day 21 of the previous cycle suppression, the candidate, the lady would get into OHSS. However, if you start antagonist protocol, the OHSS is very less. So, what about inositols? Everybody says inositol. Do you think it is beneficial? The registry guidelines is very clear. Inositols is considered, may be considered on individual preferences and values, but noting limited harm, yet with limited clinical benefits. The guidelines have not said we should use it because still under consideration. However, we can use it on individual basis and not for all patients. To conclude, understanding the pathophysiology and guidelines can streamline our thinking and the management. As you know, guidelines is too huge. I just picked up some few points which is clinical relevant, and I presented like a case scenario because that's what we get in our clinical practice. Each patient is different. However, stressing upon basically the menstrual cycles, irregularities, hirsutism, and the plus or minus androgen level estimation if you need, and of course, how we improve the category of management in different kinds of protocol. Thank you once again for the invitation.
Thank you so much, sir.
Thank you so much.
Now
Hello.
I request Chairperson. Yes, ma'am.
Thank you so much, Dr. Pratap. This was an excellent way of presenting the guidelines with the case scenarios, and it has clarified a lot of doubts, and especially the point that you said about 3 months washout period should be given before doing the sex hormone binding globulins after COCs, and the FG score in that the forearms and legs are excluded. And also that to confirm PCOS in adolescents, we can take the help of free testosterone and total testosterone. One thing I had a doubt about that you said TS, the total abdominal, I mean this trans abdominal sonography can be done if the patient is not cooperative with TVS. But is there any role of transperineal ultrasound if the patient is not cooperative for TVS?
Yeah, I think it's good, ma'am, but the guidelines have not said that. It is an individual preference, but I think if vaginal is not possible, transperineal is a good idea. But the guidelines only says either vaginal or abdominal.
Okay. And in the recommendation that the guidelines give about letrozole being used as the first drug of choice, but basically it is an off-label use.
Yeah, but it is now used for fertility in a large number, many countries it's being used.
So thank you, sir. It was an excellent talk, and especially about the lean PCOS also having insulin resistance. That is an important point. Thank you so much, sir.
Thank you, ma'am. You know, the guidelines is so huge. I would take 3 days to talk
Right,
about
very
it.
large, very large. It's not possible to
Monica
cover.
and we discussed the other day, and I said case scenarios are more important to understand in a clinical practice.
Wonderful way of presenting it, sir. Thank you so much.
Good evening, everybody. It was a, as first of all, thank you, Dr. Monica, for inviting me in this session. And it was a very good presentation by the Dr. Pratap Kumar, and very informative. We knew so many things. Thank you. Thank you, everybody.
Thank you.
Thank you, chairpersons. Thank you, chairpersons. And thank you, Pratap, sir.
Thank you, Monica, for your invitation, and all of you. Pleasure meeting you.
Sir, one of the questions was on AMH. So if, with the permission of the chair, I'd just like to ask you, sir, if you do in a particular patient, you're not able to do a TBS and you just do the AMH levels and you find the AMH levels somewhere in the tune of 7, 8 or 9. So will that patient's ovarian volume also correspond to the AMH level? Will
Yes.
that ovary be bulky always?
Because the normal AMH value is between 1.5 to 3.5 nanogram per ml. Anything above 5.5 in clinical practice, we will be considering as a PCO problem. But 7 or 8 is for sure. Because in these kind of patients, the ovarian volume will be high. There's no doubt about that. But it doesn't mean that you have to really look at the volume. But abdominally, if you do, it should be more than 10 ml. But I think I, for one, would be just counting the follicle. If more than 10 abdominally is still fits with PCOS. More than 20 is vaginally, 10 is abdominally. But your questions about AMH and ovarian volume, generally it's like that. Higher the AMH, higher the volume.
And sir, I also tried doing the transperineal sonography. What happens is when you're putting the probe on the perineum with the proper cover, whether it's a transabdominal probe or because transabdominal probe has more penetration. So if you put a transabdominal probe with a proper cover on the perineum, you might be able to access. But madam, the rays, the sound waves or the ultrasound doesn't reach the organ the way we want it. So it's better to have an adequately full bladder, a moderately full bladder. Try to take the sonic window of the bladder and reach the uterus as compared to a transperineal scan. That was my experience, but of course, that's open to discussion. Thank you so
Thank
much.
you, ma'am.
I,
Good
I
way.
have I have a query also.
Yes,
Hello.
yes, ma'am. Please go ahead, ma'am.
I want to know about the role of leucine in bringing down the AMH. What is the role of leucine?
What's that, ma'am? Oh, no, it's not recommended.
mTOR, there is some medicine mTOR.
And
They
none of them are recommended by guidelines.
But they say it brings down the AMS level. So it was a new
No,
drug for me,
all
so I
these are
thought I should ask.
individually we can definitely try, but the guidelines are very safe. They are not telling us to use those, and they're not even talking about inositol much.
In fact, madam, the guidelines make life very simple. If we follow the guidelines, our life becomes very simplified and we don't have to, wonder what to do. If you really consider the guidelines safe.
But I always felt, as madam said, there are individual variations. Sometimes you don't find response. You may try add-ons. There is nobody says don't do it. But the guidelines when you're talking about, it's not discussed.
Thank you once again, sir, for a wonderful, wonderful talk. And I had the opportunity for being a panelist, and sir was a very strict moderator. Just last week, I think. No, 2 weeks back. Yes, sir.
Jaipur, yes.
Thank you. Thank you so much, sir, for joining us and for being the star speaker of Synergy 2.
Thank you so much. And Pratik, next will be, he will always talk about lovely ideas in his mind. So I'm sorry, I just log out. I have another meeting to do. Pratik, if you don't mind, and Monica. And
Thank you, sir. It's always wonderful to listen to you.
Thank you so much, sir, for joining, sir. It was a great honor and pleasure for us, sir.
all the best.
Hope to see you again in Synergy, sir.
Thank you. Bye-bye.
Thank you.
Thank you so much, sir.
Bye,
Thank
sir.
you, sir.
Thank you.
Thank you. Now we will move forward to our next session. For the next session, I would like to request my co-coordinator, Dr. Purva, to introduce our chairperson and speakers.
Thank you, Neetu. After a wonderful session 1, we move on for the next second session, that is on visceral adipose tissue, a ticking time bomb. For this, I invite Dr. Pratik Tambe sir and chairpersons Dr. Anju Singh ma'am, Dr. Manisha Khare ma'am, and Dr. Sangeeta Thakur ma'am. Dr. Anju Singh ma'am, madam not joined because of some emergency. Next, we have Dr. Manisha Khare ma'am. Madam is presently director. Dr. Vishal, next CV. Madam is presently director and consultant Manisha Hospital. She is having vast administrative experience and has held various executive posts in Bhopal OBGY Society. She has great years of experience in OBGY, and areas of interest is colposcopy, ultrasound, and high risk obstetric. We welcome you, ma'am. Next, we have, thank you, ma'am. Next, we have Dr. Sangeeta Thakur, madam. Madam is presently Secretary Saharsa OBGY Society, Bihar. She is presently consultant gynecologist, ISER nursing home, and she has performed many surgeries, including 5th cesarean section. We welcome you, ma'am, to chair the session. Now I hand over the session to chairpersons to introduce our speaker, sir, Dr. Pratik Tambe, sir. Thank you, ma'am.
Welcome, sir. We have heard him so many times. He has very infectious smile, I must say. I was talking to Monica when I was listening to last Synergy webinar. She said this will be much better. Didi, आपको बहुत मजा आएगा. And really, it was very nice listening to Dr. Previous speaker. So let me introduce Dr. Pratik Tambe. He is MD FICOG FICRM, ART Consultant, Gynec Endoscopy Surgeon, Ashirvad IVF Mumbai, International Diploma in Advanced Laparoscopic Surgery, France, trained in Assisted Reproduction in Belgium, trained in Clinical Embryology in ICSI at London and Singapore. He is Governing Council Member, ICOG, Governing Council Member, ICRM, Patron and Managing Council Member, Mumbai Obsgyny Society, from 2013 onwards, Managing Committee Member, Indian Society of Assisted Reproduction, ISAR, 20 to 26, Managing Committee Member, Maharashtra Chapter of ISAR, MSR, past
That should be
chairperson.
enough, ma'am. That's enough. Thank you.
You're most welcome, sir.
Thank you very much. So let me begin by thanking Monica and the entire organizing team, the workers behind the scenes who make this entire series of Synergy very much sought after and very much a delightful academic event to look forward to. My talk is going to be very simple and it's completely evidence based. There's no rocket science about it. It's very simple, it's very easy to follow, and I hope what you learn from this you'll be able to implement into clinical practice right away from tomorrow itself. So I'm going to talk to you about something which we as OBGYNs don't commonly think about. And we are aware of these issues, but we often don't think about them. We don't understand when to put them into clinical practice. And hopefully, at the end of these 20 minutes, you'll be much better informed and you'll be able to put it into clinical practice. Both optimists and pessimists contribute to society. The optimist invents the aeroplane and the pessimist invents the parachute. Why did I start with this quotation? Because when you look at PCOS and how it has evolved over the past 3 to 4 decades, how our understanding of the entire disease has evolved, you'll realize that the more we delve into it, the more we go into the depth, the more we realize how little we actually know. And maybe this is one particular condition where there truly is an iceberg phenomenon. We are seeing only 5 or 10%, and there's 90% still buried deep within which our students, our children, the forthcoming generations will be able to unravel, and then they'll be actually able to treat this condition in a better fashion than you and I can ever manage in our lifetimes. Whenever I talk about something, I like to start by asking whether it's clinically relevant. You will understand that PCOS is very much relevant to this day and age in 2024. In fact, a study which was published, which looked at the global disease burden, this had sampling from 194 countries. And unfortunately, it was published in the pandemic, April of 2021, in human reproduction. That's why we probably didn't give it all that much attention or importance when it first came out. It showed that compared to 10 years earlier, 1.55 million new documented cases of PCOS were reported. Now, you'll understand that PCOS is not a notifiable disease like typhoid, malaria, chikungunya, dengue fever, all these conditions. These are notifiable. So the statistics are more or less accurate. PCOS is not a notifiable disease. So I would take this with a pinch of salt. Probably the actual figures are significantly higher. But they said that compared to 2007, in 2017, there was an increase of nearly 4.5% globally. And you look at age standardized incidence, which is a different measure compared to just standard prevalence, they found there was an increase of 1.45% in just those 10 years. And if you look at the country-wise maps, you'll find that these countries, which are highlighted in yellow, had the greatest, how can I put it, increases and leaps and bounds, which when you see compared to 2007 was significantly higher. A lot of these countries are in sub-Saharan Africa, where you'll find that a lot of dietary changes are there. There's a lot of impact of globalization. Fast foods are coming in, westernization is happening. And therefore, consequently, because of the genetic predilection, PCOS has increased by leaps and bounds. How does this actually impact the topic that we are talking about? We'll come to that in just 1 or 2 minutes. In case you were wondering, where is India in this entire scale? This gray little peak that you see just next to the African countries is India. So India is also showing increase in the numbers of PCOS, the published figures at least. And I'm pretty sure that a lot of data is unpublished in our country, which means that we are not very far behind these African countries with the yellow peaks. So let's look a little bit at the pathophysiological basis for PCOS as we understand it. We know that there is a two-side gonadotropin theory, which describes that from cholesterol precursors, you have progesterone and androgens, which are significantly higher. You know that the theca cell, which manufactures these hormones that we just talked about, is 2 to 3 times more prevalent than the granulosa cell, and therefore there is an excess of androgens. This explains why PCOS is a syndrome of androgen excess. Again, it's not rocket science. This is first or second in the base biochemistry, which we are just reiterating. But if you look at the disease process, you'll realize that as a consequence of all these issues, there are a lot of metabolic derangements which are happening beneath the surface. Some of these are recognized, we understand them. A lot of these are not recognized. We don't have direct measurements for them, and we'll come to those in just a couple of minutes. We know that PCOS is characterized by altered insulin sensitivity. You're going to have androgen excess, and a lot of excess androgens with a lower SHBG means that women are going to have a greater cardiovascular risk. There's going to be more amount of type 2 diabetes. Sometimes it gets unmasked even before they get pregnant. Sometimes it gets unmasked in pregnancy as GDA, and they will have oligo and ovulation. What is not widely known by BGYNs, because we don't actually look into these issues. These are more for people who practice internal medicine and who practice other branches. Androgens influence something called as adipokines. And this terminology also, this term to be very specific, was something which was new to me about 8 to 10 years ago when I first came across it. Until then, I will be very honest with you, I didn't even know there is a term called as adipokines. I knew about cytokines, of course, I knew about prostaglandins. Similarly, just like you have cytokines and you have prostaglandins, which are markers of inflammation in the human tissue. Similarly, you have something called as adipokines, and these are found amongst fat cells distributed throughout the body, and they function very similar to inflammatory markers like cytokines. These disturb the intracellular mechanisms, and these are one of the paramount reasons why women with PCOS become obese. You'll find that in clinical practice, especially when you reach my age and my level of seniority, we don't get the simple de novo patients. We get those patients who've gone through the half a dozen different practitioners before they come to us. Therefore, when they come to us, they have tried probably everything in the book. Lifestyle modification, been there, done. Metformin, taken kilos and kilos of it. Myoinositol, decaroinositol, वो तो दो दो तीन तीन साल से ले रहे हैं. And still, these women are not able to lose more than 4 or 5 kilos of weight, which is not a significant weight loss when they are more than 100 kilos to begin with. A woman who is 100 kilos plus, 110, 120, even if she manages to lose 5 kilos, that still doesn't count as significant weight loss, which is required when you are trying to get them pregnant, which is required when you are trying to get better quality oocytes and lower the incidence of OHSS. And one of the pathophysiological mechanisms which contributes to this is something called as adipokines. And this brings us nicely to the central concept of what we are going to talk about, and that's the visceral adipose tissue. You will find that the more the androgens which are circulating in the human body, in circulation, both for men as well as women, these excess androgens confer a male type of abdominal adiposity. And you can see that illustrated in this diagram. And this is very similar to, how can I put it? The typical Hindi movie uncle who is very fat and has a giant paunch or a beer belly, something like that. And you will find many of our Indian women who are trying to conceive, who are in their late 30s, have this male pattern distribution of central or truncal adiposity. And this is one of the things which confers in them multiple high risk for many other metabolic syndrome issues. We'll come to those metabolic syndrome issues in just a couple of minutes. If you've understood this concept, then it becomes very easy to understand the previous slide that this excess of androgens and excess of fat which they are carrying in the abdomen, which is similar to what happens in Indian males, especially, this tissue functions like an independent endocrine organ. And this independent endocrine organ has a lot of local cytokines, which we call adipokines. All of these are responsible for a chronic low grade inflammatory process which happens in these women continuously. And there are a multitude of molecules which are responsible for this. And there are a multitude of markers which have been described. We'll come to those in just one of these slides. And this is what causes all of the pathophysiology in PCOS, which you and I are not aware because these are relatively newer concepts. They have come out after we have passed out of MD medicine. And this is also what drives a very resistant kind of insulin resistance. So we are not talking about the typical insulin resistance, which gets ameliorated or is responsive to, say, walking or weight loss, metformin, inositols. No, this gives rise to a very resistant kind of insulin resistance, which is refractory to treatment. And if you want a direct measurement of this particular type of refractory insulin resistance, you don't need to do fasting insulin. You don't need to do fast prandial insulin. You don't need to do SHBG. You don't need to do AMH, FSH, LH. All that you need to measure is the waist circumference. The humble tape measure, which we in clinical practice have consigned or relegated to just taking symphysis to fundal height, is today supposed to be the most sensitive marker for abdominal adiposity, visceral adipose tissue, and resistant insulin resistance. You will find that women who have a large waist circumference, which is significantly plus 2 standard deviations greater for their ethnicity, are directly and indirectly already excellent candidates for metabolic syndrome. In fact, metabolic syndrome directly with waist circumference is also now being diagnosed in young girls who are adolescents. The first presentation of PCOS in these young girls is directly metabolic syndrome. This is the most confusing slide of the entire presentation. I'm not going to read it out, but this just shows you the amount of research and work which is being done into all these inflammatory tissue markers. Some of these will be familiar to you, like tumor necrosis alpha, tissue plasminogen activator, von Willebrand factor, the different interleukins, antiprominins that are mentioned. But there are many others as well, which are completely new to us. And don't ask me what are the reference ranges, what are the normal ranges for these molecules, because very honestly, I don't know much about them either. They are as much news to you as they are to me. And though these have been described almost 10 to 15 years ago, still normal ranges have not been defined. The extent to which we should rely on these markers to drive our treatment is not yet quantified. Maybe at some point of time in the near future, we will have different scoring systems which look at these individual markers and which will help us to individualize our treatment in these women who are refractory to treatment and who have resistant disease. There was a lovely RCOG guideline which was published 10 years back, November of 2014, Green Talk Guideline number 33, which looked at the long term consequences of PCOS. In fact, the RCOG has also got some excellent frequently asked questions. These are aimed at patients, where if they go onto the patient facing side of the RCOG, these leaflets are there which delineate what PCOS is, what it entails, what are the different things that a patient can do to keep it in check, and so on and so forth. We are already familiar with the ESHRE guideline, which has been covered excellently by Professor Pratap Kumar. I'll just quickly take you through how metabolic syndrome and the concepts behind visceral adipose tissue, excuse me, started to evolve. Way back in 2002, this is a human reproduction update, which said that excess of abdominal adiposity and resistant insulin resistance was associated with premature morbidity and mortality in women with PCOS. Further research said that women who had PCOS cluster risk factors for diabetes, cardiovascular disease, and endometrial cancer were known to suffer from complications significantly higher than other women, and there was a warning for major public health implications. Let's talk a little bit about South Asian PCOS because we're finally Indians. So let's focus on how Indian PCOS is different from the Caucasian PCOS that we all read about, which we have, seen so well addressed through many different papers, guidelines, and meta-analysis. In South Asian women who have PCOS, be they lean or be they obese PCOS, there is severe hirsutism. This occurs at a lower SHBG level. There is a higher free androgen index. There is more insulin resistance. If you look BMI for BMI, compare a Caucasian woman versus an Indian woman, you will find that the insulin resistance is more refractory to treatment in the Indian woman with the same corresponding BMI to a Caucasian woman. And also, very uniquely because of our genetic and ethnic background, there is a significantly higher prevalence of what we call acanthosis nigricans. There's a lower BMI, but there is a great amount of concentration of fat in the abdominal region, which we call as truncal adiposity. All of this translates into an early onset metabolic syndrome. And as I described, we are now seeing young girls of 15 and 16 years who are in the adolescent age who are being diagnosed with metabolic syndrome. When I was in medical college 30, 40 years back in 1990s, we were always taught that when you had 15, 20, 25 years of unopposed estrogen and androgens, that translates into metabolic syndrome. That is no longer true. You'll be surprised to know that metabolic syndrome can be the first presenting symptom complex with PCOS. And as I said earlier, these women are unable to lose or keep off weight. They have clomiphene resistance. They obviously are going to have lower and poor endometrial receptivity. Remember that in the 1990s, we were taught the problem is just getting them to ovulate. They ovulate, they'll get pregnant. That is no longer true. You can have excellent quality oocytes which are being generated. You will have fantastic grade A blastocysts. You pop them in and still you won't get a pregnancy because there's poor endometrial receptivity. There is some issue with the gene transcription which happens and the nidation which happens in these patients. And of course, there is a significantly higher incidence of CP. There are multiple papers addressing this issue over the years. This is from 2009, 2015, 2021. All of these are by eminent authors in the field. You'll recognize all these names. But I'll quickly go over in the next 5 to 10 minutes what implications this has for clinical practice. Because finally, at the end of the day, we need to understand how this impacts our patients and our clinical practice. As far as diabetes mellitus is concerned, 25 to 30% of women with PCOS are going to show impaired glucose tolerance by the age of 30. And remember, by the time they come to people like Monica and myself, they're already 35 plus. They've been trying to conceive for 4, 5 years. They've gone to half a dozen different clinicians. And they probably already are latent diabetic, but nobody has done an OGTT in them. Maybe 1 or 2 people may have done fasting insulin, but nobody's actually done an OGT. So crying out for that, that needs to be done. 8% of women who have PCOS will develop type 2 diabetes annually. The prevalence of type 2 diabetes is 7 times higher, especially in the Asian ethnic population. We are talking about South Asian women and also in North Americans as compared to Caucasians. As far as coronary vascular disease is concerned, you will find that these women have extensive coronary artery disease. Remember, we were always taught that estrogen protects women until the menopause from cardiovascular disease. It's only after the women have failure of ovarian function and estrogen levels fall, that is when their risk becomes similar to their male counterparts. That's no longer true in women with PCOS. These women have a direct atherogenic action, which occurs because of the altered lipid profile and the altered lipoprotein profile, which changes in HDL and LDL are going to impact their cardiovascular disease profile as well. There are high concentrations of triglycerides, HDL2 is suppressed, and tissue plasminogen activator, along with a whole of other adipokines are increased, which means they are more prone to cardiovascular disease. This is one of the reasons why young people as young as 35 and 40 all across the country, as you know, have been dying in gyms with no prior history of any kind of high risk. This is one of the reasons why. This is the altered lipid profile that we were talking about for reasons of paucity. We will not be able to talk about in detail. As far as hypertension is concerned, again, we know that the vascular muscle wall is converted from capacitance circulation to a resistant circulation. This is also the reason why in women with PCOS, we have a greater incidence of preeclampsia. We have a significantly increased incidence of hypertension, which is detected before 20 weeks of pregnancy, not classically after 20 weeks of pregnancy. And preeclampsia is 3 to 4 times higher in women with PCOS as compared to normal controls. This is the most interesting slide of the presentation. And if you've not been paying attention so far, this is a completely new concept which most of us are not aware of. And in fact, I studied this about 7 or 8 years back, and I found a very nice slide. This is published in the Polish Society Guidelines of 2022. What this tries to show you is that as a result of a lot of changes which occur in the circulation, women with PCOS are more prone for heart failure. Now, when you talk about heart failure, you're thinking of congestive cardiac failure or you're thinking of left ventricular failure. But women with PCOS are more prone to LVF and CCF both with a normal ejection fraction, which means that if you did a color Doppler or you did a 2D echo, you would find that the ejection fraction is absolutely normal. But because of peripheral resistance being changed in these women, because of the obesity and the compliant circulation be converted to a resistant circulation, these women are significantly more prone to CCF and LVF with a preserved ejection fraction. Completely new concept, and this is one of the reasons why Whenever your PCOS women get pregnant and they are going home with their baby, please refer them to an internal medicine specialist. They need to be seen at least once and they need to be screened. How do we screen? That's the last slide. We'll come to that in just a couple of minutes. See, endometrium is well known as one of the high risk factors for women with unopposed estrogen. The absolute numbers are low, but then the risk is great and therefore they need to be screened. Metabolic syndrome, as we said, is much higher in women with PCOS, especially the hyperandrogenic phenotype, and it's at least twofold higher in young girls as compared to normal controls. A couple of slides about metabolic syndrome, and these are management guidelines from the Polish Society of Hypertension, which I just referred to. Understand that there are four main pillars as far as metabolic syndrome is concerned. The central pillar is obesity. The other three pillars are diabetes, hypertension, and dyslipidemia. And if you are an Indian, like I am, all of us have all four of these present in abundance. There are very few people like Monica who are thin, lean, and who don't have these. Okay? Most of us have all four of these in abundance. And if you think of any PCO woman that you've seen in the OPD in the past 1 week, I'm sure you will realize that that woman has all of these either latent or overt, and you need to address that. So, how do you do that? You first look at the waist circumference, as we said earlier, towards the beginning of this talk. You look at the BMI, and you look at the additional diagnostic criteria for those three pillars. If your OGTT is abnormal, if your lipid profile is altered, or if your blood pressure is borderline or elevated, these women instantly need to be referred to an appropriate internal medicine specialist who understands the implications. The NIH criteria are three or more of waist circumference, triglycerides, HDL, hypertension, and elevated FPS. If you want to take a screenshot, this is the best slide to which to take a screenshot because this will impact your clinical practice straight away. From tomorrow, you can put this into clinical practice. The consequences of abdominal obesity are well known to all of us. It impacts all of the bodily functions, including kidneys, liver, eyes. We've talked about preserved ejection fraction and congestive cardiac failure. Obstructive sleep apnea is well known. I'm sure somebody else will talk about it. We know about the pre-diabetes. We also are aware of the implications for hypertension and dyslipidemia. So how do we counsel women? If you tell her all this, she's going to get scared and she's never going to come back to you. So you need to break it to her gently. And one of the excellent ways in which you can do that is go back to the RCOG leaflet. You can translate this into her own native language, or you can have somebody who is good at counseling explain to her in a step-by-step fashion that these are all the things that you need to look at. They should be looked at regularly. And the next question that the patient is going to ask is, what can I do to protect myself? So you need to have lifestyle modification. You need to have your food, which is altered. Excuse me. And obviously, there are multiple benefits to weight loss, to instituting metformin and inositols in time, regular health checkups, and the protocols for clinical practice as recommended by ISHRE. ISHRE and Androgen Access Society recommend 75-gram OGTT and clinical examination at least once every 3 years. And the Endocrine Society recommends that do it for everybody, including adolescents. Do not use HbA1c. The standard cardiovascular disease screening protocols as recommended by the American Heart Association. And for endometrial C, unfortunately, there is no universal agreement, but you can individualize and look at it. Finally, to conclude, ladies and gentlemen, how do we actually manage the long-term consequences and this visceral adipose tissue? Now you understand the importance of visceral adipose tissue, how it's a ticking time bomb, how you and I don't recognize it. And because we don't recognize it, we don't convey it to our patients. Because they don't know it, they will only come back to you when they already have complications. Therefore, at every visit, look at BMI and waist circumference, classify into high risk or just at risk. Complete lipid profile, LFT, RFT, blood pressure, waist circumference, and your glucose profile. If high, refer to cardiologist or endocrinologist. Look for depression, anxiety. If high risk, refer to a psychiatrist. Ultrasound, look at endometrial thickness. If abnormal, do your endometrial biopsy. Institute lifestyle modification and insulin sensitizers early. And this is from Dr. Durusha's PCOS Society of India. This is published. It's there on their website as well. Excellent resource for a lot of other counseling materials as well. Metabolism and PCOS with metformin and insulin sensitizers go hand in hand. We are aware of that. Can you control androgen excess? Unfortunately, you can try, but you need to break this vicious cycle of hyperinsulinemia and hyperandrogenemia somewhere. The easiest way to do it is with exercise. We've had an ESAR guideline published very recently on obesity. I'll share that with you guys very soon, as soon as it's out. This is the Acanthosis nigricans guideline, which was published a couple of years back. Dr. Durusha was the central figure there. I also had the good fortune to contribute to that. This is the treatment algorithm for metabolic syndrome, in case you guys are interested. But most of us would not actually treat metabolic syndrome. We would refer to an appropriate internal medicine consultant. As long as you are aware what are the pillars, how to screen, that is more than enough. My purpose will have been served. So I'll conclude with a few simple key practice points. PCOS is the hidden pandemic, confers a high risk for all metabolic disease. Classic PCOS, obese classic PCOS, confers the highest risk. Remember that South Asian PCOS is more resistant as compared to Western PCOS that we all read about. Education is important, learning is important. Unlearning and relearning what we've learned previously should be the order of the day. Thank you for a patient hearing. And thank you, Dr. Monica, for those two extra minutes.
Chairperson?
Yeah. Thank you, Dr. Tambe sir. You have excellent talk on pathophysiology of PCOD. Some topics I did not know. You have taught some new topics, sir. Pathophysiology and guidelines. Very new topic. Thank you, sir. And
So may I ask a question?
Of course, please.
Yeah, so we see that the androgen levels are high in PCOS, but still during the treatment of infertility, we see some people prescribing DHEA tablets.
So as far as PCOS is concerned, there is one school of thought which feels that in women with PCO, you get a lot of oocytes, but unfortunately, they're not very good quality. So in women with poor ovarian reserve, we typically prescribe androgens to improve the oocyte yield and the oocyte quality. That's why androgens are prescribed. Some people like to extend that analogy to PCOS as well and like to add androgens there to improve the oocyte yield and quality. Typically, this is not required. What you require in women with PCOS is not androgens. You need to have something called as mitochondrial rejuvenators, which take care of the reactive oxygen species and improve the oocyte quality. Those will be much more evidence-based, and those will be more appropriate in women with PCOS as compared to androgens.
Thank you, sir. And the other question was that for improving the insulin resistance, to reduce that, any specific drug?
So the best insulin sensitizer, I'm very fond of saying, is something which you can't prescribe, something which you need to put into clinical practice, and that is exercise. Exercise is the best insulin.
Thank you, sir.
Second best is all the other drugs that we have. Metformin, we have the largest evidence base published in the past 4 to 5 decades. Inositols are not very much favored in Western countries because they're not available as part of their armamentarium. They are licensed for use in India, but unfortunately, there's not much Indian data that is published. They work well in certain classes of patients. And there's a new kid on the block called as berberine, which is now recently available. And berberine seems to be doing quite well. In the small trials that we have with limited numbers, head-to-head comparisons with metformin as well as inositols have shown that berberine is better than both. But we need to have large volume data before we can make a recommendation. Okay.
And semaglutide?
semaglutide is something which is addressed in the new ESAR guideline. So maybe I'll come back and talk about it in another episode of Synergy.
Thank you so much, sir.
Sir, some patients respond very soon for infertility treatment in PCO cases, and some takes a very long time. What may be the reason, sir?
So one of the reasons, as I just said, is poor oocyte quality. Second is that they have a lot of metabolic issues which are there lurking beneath the surface. Third, the issue becomes that we are focused on PCOS all the time, but there may be other factors also at play. And fourth and most important is that after you tackle all of these issues, ultimately the endometrial receptivity seems to be affected in women with PCOS. And that is a barrier which many of us find challenging. We try our best to overcome it, but sometimes we can't overcome it so easily because of the complex pathophysiology, which we still don't understand so well.
Thank you, sir. Thank you.
Thank you for a
Thank you.
wonderful talk, Dr. Pratik. That was one of the best set of slides I've seen for a long time now. Congratulations.
Thank you.
Because the perfectionist that I know you are, your talk and your slides were totally like I was, bowled over. Totally.
Thank you,
Thank you
Pat.
so much. Thank you so much for the fantastic presentation. And we are very honored to have
Thank you, Dr. Monica, for writing me.
Thank you, ma'am. Thank
And
you.
Dr. Monica, thank you for
Thank
making part of such a great CME.
मैडम
Thank you,
आपको
madam.
मैडम आपको बार-बार आना है हमारे यहाँ.
Okay. Thank you, madam. Welcome, madam. I will be honored.
Thank you so much.
Thanks, ma'am. Okay.
Thank you, Pratik, again.
Thank you.
Thank you.
So carrying forward the session, now I hand over the session to Dr. Nandini to carry forward for the third session.
Thank you, ma'am. Good evening to one and all. After a very educative session, moving to our final session on a very thought-provoking topic by our own convener, Dr. Monica Singh, ma'am, on the topic of why should you know about PCOS phenotype. The session will be chaired by Dr. Lata Gupta, ma'am, and Dr. Varna Pathak, ma'am. Lata Gupta, ma'am, who is the Secretary of Sitamarhi Obstetric Society, and Dr. Varna Pathak, ma'am. Lata Gupta, ma'am, she is a consultant in Lata Nursing Home. She is also the founder secretary of Sitamarhi Obstetric Society. She is a chairperson at national conferences and as an eminent speaker in various webinars. Madam has received MS Signature Award for her outstanding contribution in women's health. She has been the past president of Lions Priyadarshini Club. She is a lifetime member of ISOPAB, IMA, Red Cross, and Lions Center Club. It's a privilege to have you, ma'am. Our next chairperson is Dr. Varna Pathak, ma'am. Madam has been the past secretary of Bhopal Obstetric Society. Presently, Madam is professor in the Department of Obstetrics and Gynaecology in Ramakrishna Medical College, Bhopal. She has a wonderful experience of more than 2 decades, and her areas of interest are high-risk pregnancy. Madam has been elected as the chairperson of Women's Wing, IMA Greater Bhopal. Presently, she is the executive member of IMA Bhopal. She has been an accomplished academician. She has received a gold medal in her undergraduation, and Madam has been a postgraduate diploma in clinical research symbiosis. It's a proud privilege to have you with us, ma'am. I request my chairpersons to kindly introduce the speaker for today. Please. Lata, ma'am.
Good evening. Thank you so much
Yes,
for inviting me as the chair to chair this session.
Thank you, Dr. Nandini. Thank you so much for that lovely introduction. And may I
Thank
take
you,
the proud...
Am I audible? Hello?
Can I take the proud privilege to be introducing the convener of the program today, Dr. Monica Singh, one of great pearls of the Bhopal Obs and Gynae Society. So Monica ma'am is a consultant for reproductive medicine. In fact, to her goes the credit of having the first infertility center of the city of Bhopal. Madam is a professor at LN Medical College, Bhopal. Managing committee member of ISAR, is the vice president of Bhopal Gynae Society, Bhopal Menopause Society, honorary secretary to MP chapter of ISAR. Ma'am was the West Zone coordinator for the Medical Disorders Committee, is the West Zone coordinator for Medical Disorders Committee, FOXY.
That's okay, Varuna.
In fact, actually, that will take a lot of time to introduce you, Monica Didi. You have
No,
so
it's
much
okay.
to be spoken about.
I'm really honored to have you chair the session, Dr. Lata and Dr. Varuna. And I'm really, my task has been made very simple by the great talks we just had from Dr. Pratap Kumar and Dr. Prateek. So my talk would be something like maybe not very something different, but I don't have my slides open.
But it is so very important to know. We've been listening to the PCO since the past two speakers, and it's about myoinositol, and it is about metformin, and it's about exercise. So, how is a lean PCO different from an obese PCO? We need to know it in detail to be able to, precisely pinpoint everything about it. To learn that it's not one size fits all. No, it's not like that. To understand that, we got to sit through your session actually.
Okay, so I'll try to do justice to whatever you are saying. I'm God the brains to get it across, though I did a lot of hard work trying to get this lecture together, and let's hope I can do justice to the whole talk. I'm having a little bit problem with my laptop, but yeah. Stop sharing. So can you see my slides?
Yes. Though it's not on slideshow.
Yeah, I'll do that.
But yes, we can see your screen.
Yeah.
It has started screen sharing.
Yes.
Now it's good. Yes, it's good now.
So after the fantastic sessions we had talking about clinical scenarios of PCO, taken in a very interesting fashion by Professor Pratap Kumar, and the absolutely brainstorming session on metabolic syndrome and how it is related to obesity and how it's a time bomb in the making. We would like to modulate our therapy and make it more evidence-based by knowing about PCO phenotypes. Because unless we know about the phenotypes, we'll not be able to actually target our treatment to where it is required. So, what is PCO and why should we know the phenotypes? This is because of the incidence. We have, literally 1 in 10 women suffering from PCOS now. And besides this huge prevalence all over the world, a large chunk of these women go undiagnosed. A large proportion of these women, as we studied, are going to develop type 2 diabetes as well as cardiovascular complications as soon as they start approaching the age of even 30s. There is a huge burden on the health exchequer of every country which is put by PCO, and very many of these patients might face malignancy as they age. So the whole scenario is actually related to fertility treatment, but as we study the phenotypes, we'll also study about the effects on general life of the woman, her endometrial status, her hormones, her mood, her psychology. And definitely for that, we require the phenotypic classification and evidence behind it. So a lot of our talks have been based on the Monash guidelines, because whenever new guidelines come, I think the fertility specialists are the people, and the endocrine people are the first to read the guidelines, because as such, our field is filled with so many add-ons that you cannot use all the treatment on everyone. So these guidelines by Helena Teed and her group actually originated from Australia, but they have inputs from all over the world. And they have really simplified treatment of PCO. Now, besides being one of the most common endocrinopathies in reproductive aged women, What I would like to say about PCO is that we started way back with very good evidence behind PCO in the form of the diagnosis by Rotterdam's criteria. The simple Rotterdam's criteria were started in 2003, formulated by a group of people who got together in a place called Rotterdam under the ESHRE this thing conference. And they included oligo or anovulation, they included hyperandrogenism or hyperandrogenemia, and they included the polycystic ovarian morphology. Now, everything of this is defined by the guidelines, whether the number of cycles, the days of the cycles, how to diagnose in adolescent, how long not to diagnose in adolescents, which modality of ultrasound to use, what should be the ovarian volume be, what should be the antral follicular count per section, what should be the follicular number per ovary, what is an antral follicle, when it cannot be called an antral follicle, and what are the phenotypes. So I encourage all youngsters and clinicians that if they really want to understand PCO, they should master their biochemistry and they should master the anatomy of the subject. So when we see phenotypes, it's very simple. It's about A, B, and C and D phenotype. So phenotype A is basically the complete or classic PCOS. Phenotype B is also a classic PCOS with some difference from phenotype A. Phenotype C is the ovulatory PCOS, a woman who has regular cycles, and you will find documented ovulation on ultrasound. She can, do it on an LH kit. And the phenotype D is the non-hyperandrogenic PCOS who doesn't have any features of raised androgen in the body. Now, whenever this population comes to us, more of this population comes to the clinicians, and a few of this is in a random unselected population. So this referred population who comes to a fertility clinic or to a hospital or to a gynecologist will have maximum patients more than 50% as phenotype A. As you can see the yellow figure, most of these patients are complete PCOS with all the three features of Rotterdam. And the rest of the B, C, and D in the referred population which comes to a fertility unit are equally distributed. But if it is an unselected population, which is not going to any particular doctor or specialist, then you can see the maximum cases are the non-hyperandrogenic PCOS, which do not have raised androgen. They just have a polycystic appearance on ultrasound, and they have irregular cycles, and the rest are equally distributed. How this is important, I'll be touching in my forthcoming slides. Now, PCOS classification is also something of a confusing thing for the general gynec who is not dealing with it every day. So the history goes back to the National Institute of Health classification in the 1990s. That's the time most of you were doing post-graduation. Even I did post-graduation in the 1990s. So this criteria came there, and this had the features of hyperandrogenism with oligoovulation or anovulation. And both of these criteria had to be positive in order to be called, PCO. Then ESHRE, ASRM got together in 2003. They formulated the Rotterdam's criteria, which required any two of these three positive, that is hyperandrogenism, uh, PC, polycystic ovarian morphology, and oligoovulation or anovulation. So it did not require that all three had to be positive to be called PCO. Then the Androgen Excess Society thought that Rotterdam's is not playing a fair game for the patient. So the Androgen Excess Society of or APCOS came forth with a concept in 2006 wherein they wanted hyperandrogenism to be included compulsorily in the diagnosis of PCO. So they wanted hyperandrogenism to be there, and ovarian dysfunction could be either oligoovulation or a polycystic ovarian morphology, but the androgens had to be raised and both the criteria had to be positive. It was in 2012 that Rotterdam's was modified and the phenotypes came about. Again, hyperandrogenism took a backseat. All the three criteria became equally distributed and the phenotypes came around. So before I describe the phenotypes, I would like to speak a little bit about the, how they are called classic and why they are called classic. The classic PCO or the complete PCO is the most severe phenotype of PCO, which is the type A. So this has got all the three features of Rotterdam's positive. And most interestingly, it is the most common phenotype which will be there in your practice. So from tomorrow onwards, if a patient of PCO walks into your room, by the law of probabilities, there is more than half 50% chance that she'll be a type A. That is a complete PCO. On the other hand, there is a classic PCO which has got everything of A, but it doesn't have the classic morphology. Here you can see the picture of the necklace sign of the ovary in PCO. This is a transvaginal scan, and it is called the string of black pearls because all of the peripherally distributed follicles which are not mature, they are of the size, they are antral follicles. The central stroma is thick and ecogenic, and all the follicles form a necklace sign. So this pattern will not be there in phenotype B. Otherwise, it is a classic PCO like A, and these form only 10% of the patients. Third is the ovulatory PCOS, which is C and D are the mild types. Usually, when we go through a alphabetical order or a numerological order, A, B, C, D, you think A and B are mild and C and D are more severe. In here, it is exactly the reverse. A is the severest. B is also severe case of PCO. C and D are the mild ones, and D is the mildest. So the incidence of C or the ovulatory PCO is nearly 30%, and the D category, that is the normoandrogenic phenotype, where the androgens are completely normal. You will get normal body mass index. You will get a lean and thin patient. You will not find insulin resistance. You will find a free androgen index, which is normal. But they show increased levels of LH, and they will also show a deranged LH-FSH ratio. This forms less than 5%. So again, I have talked about polycystic ovarian morphology. We have discussed how to diagnose. We will not waste time on this and come straight away to the PCO phenotypes and their management. We have discussed how NIH consensus of PCO diagnosis is different from the Rotterdam's consensus and what is the importance of each. Now, if I talk about phenotypes like this, you'll think about it, you'll forget, you'll probably write it down, then revise. But remember, everything which is memorized needs revision. There is hardly a person who is, so that brain is so highly developed that on one reading you can absorb, assimilate, digest, and produce it like the same thing. So this is very confusing. The classic PCOS A, the NIH PCOS B, the ovulatory PCOS 3, and non-androgenic PCOS 4. So we'll try to classify it and make it simple for you to memorize. And then, of course, you will have to revise again and again till at the end of a month or 6 months, you will start thinking about it at the subconscious level without even thinking what I have, memorized. So the phenotype A is the full-blown syndrome of PCOS. It is called the complete PCOS. It's also called classic. You have got hyperandrogenism, you have got ovulatory dysfunction, you have got PCO ovaries on ultrasound. So all three are positive, and the incidence I already told you is more than 50%. Phenotype B has got non-PCOM PCOS or NIH PCOS. So these women, if you put the TVS probe, you will not see polycystic ovaries. You will see normal ovaries. But at the same time, they will be having hyperandrogenism. They'll have oligo or anovulation. So that is why this is called NIH PCOS, because NIH gave only two criteria, hyperandrogenism and ovulatory dysfunction. And it is also called non-PCO PCOS because you don't see polycystic ovaries. The incidence is less than 10%. This is also a classic PCOS. Third is the ovulatory PCOS, which is type C. This is one of the milder types of PCO. Women are usually leaner. They don't have that much of the incidence of obesity. So in ovulatory PCOS, this woman will give you the history of regular menstrual cycles. So when you do the test, you'll find as soon as you insert the probe, you'll get polycystic ovaries, and you will definitely get hyperandrogenism. And for revision's sake for all of us, like Dr. Pratap Kumar has said, now estimation of free and total testosterone and estimation of free androgen index has got a strong recommendation as far as estimation, diagnosis of clinical and biochemical hyperandrogenism is considered under Monash guidelines. So this is ovulatory PCOS type C, and this makes up about 30% of the cases. And type D is the least common. It is non-hyperandrogenic PCOS. So this woman or this girl does not have any features of androgen excess. She will not have any facial hair. She'll be lean and thin, but she will be having polycystic ovaries on ultrasound, and she'll be having ovulatory dysfunction. The incidence is quite less, and these are relatively milder to treat as far as treatment is concerned. Dr. Pratik has already told us about the Asian women and how we are sitting on a time bomb of metabolic syndrome because our overall BMI is less, but we have the propensity or the tendency to develop central obesity, especially with the type of carbs rich diet we eat and less of proteins, and definitely the lower socioeconomic status. As the socioeconomic status of a country rises, so does the health facility, how they inculcate lifestyle changes, lifestyle modifications, the female education. That is a totally different topic, but definitely your diet and lifestyle changes depend upon the educational status and the overall development of the country. So this is how, the Indians stand as far as the world scattering of PCOS cases is concerned. Now, as far as the clinical implications are concerned, do phenotypes influence the severity of the clinical conditions we are facing, the metabolic risks, the fertility? What is the influence of ethnicity? So different phenotypes are exhibiting different range of metabolic dysfunction. And the phenotypes which have more of hyperandrogenism will have more severe metabolic abnormalities. So the severe metabolic abnormalities will be seen in phenotype A, B, and C. But since phenotype D is non-hyperandrogenic PCO, it will have the least amount of metabolic abnormalities and will benefit with very minimal lifestyle changes. And all these dysfunctions become less obvious with age, in particular following menopause. The obesity will impact the severity of metabolic function in a negative way. Metabolic syndrome in PCOS is different in different phenotypes. I've already told you. They have not talked about the classic PCOS A, but all other conditions whether it is hyperandrogenemia plus oligomenorrhea, these women are the most at-risk group for metabolic syndrome. Obesity increases and has a negative bearing on the A and B phenotypes. Higher the BMI, greater is the prevalence of irregular menstrual cycles, more is the problem of androgen excess and hirsutism. Similarly, these women will have more of LDL, more of VLDL, less of HDL, and more of triglycerides. And all these markers also point to a greater risk of cardiovascular disease and type 2 diabetes. So as I told you, in these women with ovulatory dysfunction and hyperandrogenism, that is phenotype A and B, the hormonal and the metabolic disruptions are more. So not only do these women have got problems conceiving, but once they are pregnant, the obstetric complications are also a lot. So you will find more incidence of miscarriages. The miscarriages which happen in spontaneously conceived patients and in IVF and IUI pregnancies are totally different, as we'll talk later. There is a greater incidence of GDM, PIH, FGR, antepartum hemorrhage, the gestational age at delivery, they're more of preterms. The ABGAR scores are poor. And of course, fetal malformations, we are not, commenting on it because the studies are ongoing, and very many of these patients may present with intrauterine death. Insulin resistance is highest in the group of patients with irregular, IM here stands for irregular menses. So this study says that the insulin resistance is highest in the women having irregular menses and hyperandrogenemia. The HDL levels, which is the good cholesterol, is lowest, and they also have highest incidence of metabolic syndrome as when we study their weight vis-a-vis their condition. Talking about psychological parameters and how they are related to the reproductive phenotypes, So when psychology and anxiety depression of these women is considered, all the phenotypes have almost the same quality of life and psychological function in PCO, because somehow the disease may be related to one or the other parameter which brings down their quality of life. And this is one aspect of the patient we have to touch when the patient walks into your clinic. I'll now be speaking on the next 5 or 6 slides on the fertility outcomes in the different phenotypes, because this area is of interest clinically also, and I wanted to put it across. There is something called clomiphene resistance, which was studied earlier, but now we have got letrozole also, which is the drug of choice in PCO. So when we talk about clomiphene resistance, this is significantly common with a very high level of significance in phenotype A, whereas phenotype D, which I told you is non-hyperandrogenic PCO phenotypes, they are better clomiphene responders. So in phenotype A, it is a good idea to start with a higher dose of letrozole, or probably switch over from CC to letrozole early on in treatment, or you can increase the dose of CC consecutively as you do the IUI or the other cycles. Similarly, talking about the proportion of metaphase 2 or mature oocytes in IVF cycles, how they are fertilized, how is the outcome of the fertilization in the lab, what is the quality of the embryos you obtain for transfer, you will find that the highest incidence of low quality oocytes is seen in phenotype A and B. This has got a direct proportion relation with the insulin resistance these patients show, as well as the obesity they suffer from. So there is a, effect right from the oocyte quality to the embryo quality. And Dr. Pratik also talked about the endometrial receptivity because of certain transcriptase and gene modulation. So like in endometriosis, we were taught that everything is poor quality, whether it is, the egg quality, the endometrial quality, the tubal motility, implantation. So similarly in PCO, we will have hurdles at every step. Talking about fertility outcomes, there are two conditions we consider, which I mentioned earlier, miscarriage or abortions and OHSS. As far as ovarian hyperstimulation is concerned, PCO is the only condition where hyperstimulation may be seen in the current 2024, because rest of the cases we have overcome hyperstimulation. Almost all the clinics are now OHSS free clinics, but phenotype A requires longer duration of stimulation in IVF cycles. With that response, you have to cross a threshold. So once you cross the threshold, the response may be suddenly, like a thunder. It may be just, a very high response with a higher risk of OHSS in these patients. Whereas phenotype B, now phenotype B is also classic PCOS, but still it will have the lowest risk of OHSS because the ovaries are normal size and normal volume, and they don't have the typical PCO morphology. So phenotype B will have a lower risk of OHSS once you see the ovaries are normal. The risk of miscarriage is more. Spontaneous miscarriage in spontaneously conceived pregnancies is more in phenotype A, B, and D as compared to phenotype C. Now, phenotype C has less incidence of miscarriage because it is an ovulatory PCOS. So because of the regularly occurring ovulation, the LH and everything is balanced in such women, and LH excess is not there. So these women will have less of spontaneous miscarriages. But after IVF, you will find that A, B, C miscarry more than the phenotype D, which is because of the androgen levels. Because D has got less of hyperandrogenemia, that is why it has got less risk of miscarriage if you do an IVF cycle for this woman. Talking again nicely about the phenotype D, this is the good phenotype. So oligoanovulatory patient with PCO without hyperandrogenism, that is the phenotype D, have relatively mild endocrine and metabolic features of PCO. So this is a woman you would like to diagnose and treat, and she will respond nicely to your treatment. Similarly, I was asking question to Dr. Pratap Kumar about AMH levels. It is the phenotype A, that is the complete PCOS, which also exhibits the highest AMH levels. And because of the high AMH levels, the severity of oligo-ovulation is also very high, leading sometimes to complete anovulation and huge bulky ovaries. These women will also show high circulating free androgens in the blood, and the LH and AMH levels are also significantly high in phenotype A as compared to phenotype C and D. We have already talked about the quality of oocytes. A full-blown PCO will have poor morphologic quality of the eggs, and they have got all these cardinal features of PCO, oligo-ovulation, hyperandrogenemia, and PCO morphology will adversely impact the oocyte quality which goes into the lab. Now, very many times I found in the earlier years of my IVF practice, these oocytes of PCO, they looked so good on ultrasound, but when we used to do oocyte retrieval and transfer these oocytes to the lab, there used to be a dark center. So the embryologists used to say there's a dark center at the middle of the oocyte, and the fertilization outcome, even after ICSI, is not that great. It's probably the quality, oocyte quality here, which matters. So PCOS phenotype B has got poor IVF ICSI outcome. That is the correlation between the oocytes retrieved and the embryos formed. The PCOM morphology carry an advantage of number of oocytes retrieved, better quality oocytes if there is no hyperandrogenism, because hyperandrogenism and chronic anovulation in these patients will lead to poor oocyte competence, negative impact on embryo quality, and also a decreased clinical and ongoing pregnancy rate. Clomiphene resistance, as I told you, is significantly more common in phenotype A. And sorry, this is a repetition of the same slide. This is also a repetition. I'm sorry, I could not edit the slides. Yes. Now, this is very important. In phenotype A and B, we know there is high level of circulating androgens. And for every 1 picogram per ml increase in free testosterone in these women, the clinically confirmed pregnancies can fall by 50 to 60%, and so also the proportion of live birth. So this is very important when you're counseling this patient for IVF. The risk of miscarriage we've already talked about. Similarly, the phenotype A require longer duration of stimulation, a higher risk of OHSS, and phenotype B, because of the good morphology of the ovary and lack of PCOM, will have the lowest risk of PCOS. So overall, the birth rates and the carry-home baby rates, the ongoing pregnancy rates are better in phenotype D as compared to phenotype A, B, C. And for all practical purposes, C and D are the good phenotypes, and A and B are difficult to tackle as far as fertility is concerned. High BMI and insulin resistance are taken as risk factors for spontaneous abortion. This was a beautiful paper which has been published recently, 3-4 years back, and you can go through it as to find out what is the why is there an increased risk of spontaneous abortion in PCO patients. Hyperandrogenism has got a correlation with the lower live birth rate, and you can see in PCOS phenotypes A and C, you are seeing a live birth rate as less as 16 to 18%, and the cumulative live birth rate of 25 to 27%. But the same phenotype D, you are seeing a live birth rate of 33%, which is like the normal population we deal with, and the cumulative pregnancy rate of 48%. So so this is all about the cumulative live birth rate in these patients. And this is another interesting chart which I thought I'll tell you about. Now the metabolic syndrome of PCOS is also known as the endocrine metabolic syndrome. The phenotype A of PCOS is also known as PCO-EMS type 1. The phenotype B is known as the PCO-EMS type 2. And the phenotype D is known as plain PCOS. So here you can see in the A, B, and C phenotypes, the endometrial thickness is less than 5 mm in all the 3 cases. So you will have less tedious monitoring of endometrial thickness to do in these patients. But the phenotype D, because it is non-hyperandrogenic PCOS, it will have more of unopposed estrogen in the body. So it will have more incidence of endometrial hyperplasia in these patients, which will require monitoring. And these patients, phenotype D, are also prone to a future endometrial hyperplasia leading to endometrial cancer. which is 3 times more common as compared to the general population. But the dermatological complications and the related risk of diabetes, hypertension, infertility, cardiovascular problems will be more common in phenotype A, B, and C. So as we go from polycystic ovarian syndrome adult phenotypes from A, B, C, and D, now I think I don't need to tell you which is the types. You must have memorized it by now. And in the A, B, C, D sequence, there is decreasing clinical severity as far as all treatments for metabolic syndrome as well as infertility are concerned. A very beautiful Venn diagram has been given in the recent papers where they have also, stressed on the overlapping features of this syndrome. As you can see, phenotype A is in the center of the Venn diagram, which has got, a portion of all the 3 circles, oligoovulation, PCO morphology, and hyperandrogenism. So the severity is the maximum. So also in B, and it is least in C and D. Now, another very important concept is the relation between insulin resistance and hyperandrogenism, which has been already touched upon by Dr. Pratik. So, insulin resistance actually leads to hyperandrogenism because of increased androgen synthesis in the ovarian theca cell, as well as decreased production of sex hormone binding globulin in the liver. So, the circulating free androgens will lead to increased central obesity and abdominal obesity in these women. So this is how the abdominal obesity takes place, or it grows in such women, forms a male pattern of obesity. And these adipocytes, which Dr. Pratik mentioned, these adipocytes are actually producing a lot of inflammatory factors, which further increase the peripheral insulin resistance, which lead more insulin to be secreted in the body. And this insulin in turn leads to greater secretions of androgens from the ovary and the adrenal cells. And these are all the androgens which are being produced by the ovarian theca cells as well as from the androgens in a female, which lead to the disturbed androgen estrogen balance. So it is very evident that obesity is a state of chronic inflammation, and this has a huge role to play in the etiology of metabolic syndrome. That is why Dr. Pratik was mentioning that this metabolic syndrome doesn't require 1 or 2 decades to appear. It may be there as soon in life as in adolescence. And PCO, in the end, is a disease of chronic low-grade inflammation. Very soon, maybe in the coming decade, we may have some anti-inflammatory markers or anti-inflammatory drugs, like our general, NSAIDs, or maybe a class different, which can control the inflammation related to obesity. But all said and done, the best would be to lose weight and follow a diet and exercise pattern. Now, a little bit about the hyperandrogenism. So whenever there is hyperandrogenism, there is increased pulsatile release of gonadotropin releasing hormone from the hypothalamus, which leads to the increased production of beta subunit of luteinizing hormone, or LH. And that is more, the LH released is more than the beta subunit of FSH released, which causes a classical hallmark of LH disturbed LH FSH ratio in these women. And because of the increased LH production, most of these follicles which start getting produced in the ovary are arrested in the pre-antral and antral stage. The antral stage of these follicles is somewhere between 2 to 9 mm in diameter. Pre-antral is even smaller. So this leads to hyperplasia of the theca cells, accumulation of follicular fluid, and the pearl-like sago grain appearance of a typical polycystic ovary. And the Monash guidelines has very clearly said that nowadays you don't need to, look at evidence. You can calculate the free testosterone, free androgen index, and the total bioavailable testosterone in order to confirm the diagnosis of PCO in your woman and convince her to start proper treatment and lifestyle changes. So this slide just tells you how the focus of treatment of in a PCO shifts in the young age and the older age to different criteria. The younger woman is, or the adolescent will be basically dealing with irregular size cycles, worried about the skin, dermatology and everything. Once the woman reaches reproductive age group, she'll be more worried about the, conception, fertility issues, pregnancy complications. But as this woman grows older, she'll be combating the metabolic disorders, type 2 diabetes, cardiovascular disease, and probably a cancer. So this is how you have to deal with the PCO patient as soon as she walks into your clinic, even at the age of 14 years. So don't take it lightly. You have to be aware of phenotypes. You have to be aware of the obesity time bomb. You have to be aware of the guidelines if you have to be an astute clinician. So this is just a revision. If anybody wants to go through my slides, you can ask me. And in the end, I would just like to say that ovulatory PCOS may be the mild form of classic PCOS. So passage from classic to ovulatory PCOS and vice versa. So actually A and C, you now must be remembering there is a classic PCOA and there is ovulatory PCOC. So actually PC phenotype C is actually the milder form of phenotype A, and phenotype A can convert into phenotype B if they can control their weight and start having regular cycles. So this is how A and C can change between themselves. Again, a word about this slide. Most of the obese patients you will see, almost 55% belong to phenotype B, and most of the lean and thin patients you will see belong to phenotype C and D. And on the contrary, we used to think that lean and thin PCO are difficult to treat. It's not like that. If they belong to phenotype C and D, the treatment is simpler as compared to phenotype A and B. So I think that is almost the end of my lecture. I have given my take-home messages. I've talked about hormones. I've talked about phenotypes. And there's another concept called metabolic onset of PCO and ovarian onset of PCO. So another paper might be coming soon, which says that phenotype A, B, C of PCOS have got a primary metabolic onset, and type D has got an ovarian onset. That is why it is not so severe. Thank you all for a patient listening.
Thank you, Monica Didi, for that wonderful talk. In fact, you actually so precisely have clarified. In fact, you've given us a new approach to be looking at these women, that going into the absolute details of how the similar looking people are actually not so similar.
Yeah,
And
I mean, so many of my doubts were also cleared, Varuna, because I had to work on this lecture, not this time. I've been working on this lecture now since a couple of months. I've been improvising that's why so many slides are there which have to be, taken away. But all said and done, it has made a difference to my practice. So I think it should be inculcated like the Poseidon criteria. These guidelines can be easily, because PCO is not a patient who is only walking into my IVF center. She'll be walking into your clinic. She'll be going to an obstetrician. She'll be going to, high risk pregnancy specialist, everyone.
yeah. So, in fact, this is actually going to help everyone who has sat through this, your talk today, so as to be more tailor-made and more precise for the benefit of the treatment of their patients.
Yeah.
Thank you for that wonderful talk, Didi.
So thank you, Varuna, for chairing my talk, and thank you, everyone. I think everyone is now, it's past 8. It's about 8:20 dinner time. So Kumudni Jha madam is still there. Thank you so much, ma'am. And I'm always grateful to you for your inputs and always being there. And Nandini, Purva, Neetu, thank you. Thank you, Dr. Vishal. I think we will have another episode of Synergy webinar, episode 3. The topic is yet to be decided. If there are any inputs, you can always give me. We can plan a synergy around your suggestion. And this synergy will be somewhere before Dashera. And Varuna, we would like to have a fantastic talk from you also in the near future.
My pleasure. That would be my absolute pleasure.
I know you are a very passionate speaker and a very good speaker. And thank you so much. Thank you so much. Wish you all, wish you all a very happy Navratri and happy fasting. That's that's going to come, huh? And Vishal is in Gujarat. So Gujarat may happy this Vishal Dandiya and all, na?
Daily,
Garba,
daily
happy Garba.
Navaratri.
Okay.
Garba.
Thank you. Thank you so much. Thank you. Bye-bye.
Thank
Good night.
Thank you.